Welcome and thank you for joining us for tonight's webinar. I'm Panita Moore. I'm Director of Sharsheret Israel Support Services. I just want to give a few housekeeping items. Today's webinar is being recorded and will be posted on Sharsheret's website along with the transcript. Participants' faces and names will not be in the recording. You may have noticed that you were muted upon entering the Zoom. Please stay muted during the call. We will hold a Q&A, a question and answer session at the end of the presentation. If you have any questions during the presentation, please type them into the chat box and we'll try to get to as many as possible during that session. I just want to remind you that Sharsheret is a national and international not-for-profit cancer support organization and educational organization and does not provide any medical advice or perform any medical procedures. Our full medical disclaimer is in the chat. Okay, this is our second Israeli webinar in our new series highlighting cancer experts from Israel. Sharsheret opened its office in Israel just over a year ago to expand Sharsheret's mental health support and educational programs. We are now offering English speakers, confidential and local one-on-one emotional support and mental health counseling, patient navigation to work through the complex Israeli medical system, and peer support to connect with other Israeli women facing similar diagnoses. If you or someone in your family or someone you love is facing breast cancer or ovarian cancer, or they have an increased genetic risk for cancer and is living in Israel, please don't hesitate to reach out to us. Below is our Sharsheret Israel website and my contact information. The topic of this evening's webinar is the challenges facing women dealing with surgically induced menopause, which in simple language means removing of healthy active ovaries as a risk-reducing procedure, or menopause as a result of cancer treatment. Menopause is accompanied by many physical and emotional symptoms, including mood swings, hot flashes, decreased energy, sleep disorders, decline in sexual drive, osteoporosis, and the list is never ending. Tonight, we will hear Dr. Srebnik's insights to this challenge. But before we welcome Dr. Srebnik to the screen, I am happy to welcome Shira Reinhardt, who will share her story. Shira?
I just unmuted. Hi, everybody. Thank you. I'm very, very happy to be here. My name is Shira Reinhardt. I currently and have been living in Israel for the last 12 years. I am 48 years old. When I was 32, I was diagnosed as a breast cancer BRCA1 carrier. I was told that I would be chances are I would have received cancer if I didn't go and get tested for it, that the chances of me getting cancer, breast cancer specifically, were 88%, and then ovarian cancer was 45%. So I knew that my window of opportunity for taking care of my own health was in my hands, and then that window was closing. So at 36, I went ahead and I got a bilateral prophylactic breast mastectomy, and I was encouraged to have my ovaries removed by the age of 40. Everybody kept saying 40 was that kind of like magic number. I had till the age of 40 to take care of my ovaries, and I knew that it was going to come with some challenges. That long laundry list that Panina was discussing, I experienced all of those things. At the age of 40, I was now already living in Israel, and I was being kind of taken by my hand with the Noga clinic in Sharsheret. I went ahead and I had my surgery done at Sharsheret Hospital, which is significantly different than the way things are done in America. I had to go through a board. I had to be approved. They issued me a date to have my surgery, and I had to spend the night before in the hospital getting all set up, which was a lot different than the way things were run in America. I had also met with a male doctor who encouraged me to have my HRT therapy in place the second I finished the surgery. And so within a week of having my ovaries removed, I instantaneously experienced what it meant to have a hot flash. I really had no control over my mood swings. I was definitely sleep deprived. There were a lot of issues that definitely came about, and therefore I knew I had to get on the hormone replacement therapy. They said that the best thing for me to do would be to go on the patch system, which meant alternating stickers, kind of like a hormone in these stickers that I would place on my body and alternate every 3 days from one side of the body to the other side of the body. And to say that that didn't come with its own set of problems, it most definitely did. The stickers themselves would get caught on my clothing. I would sometimes forget. Maybe it would be 2 days, maybe it would be 3 days. And the doctor as well had encouraged me to fabricate my period because I ended up maintaining my uterus, but I had both my ovaries and my fallopian tubes removed. They wanted me to still fabricate a period. He said I didn't need one once a month, but once every 3 to 4 months was sufficient. So here I am now in charge of my own body, really in my hands. And I went about this process of alternating the patches every few days. Every few months, I'd fabricate a period. And this went on for about 2.5 years. At around Corona times, I had these surgeries done in about 2017, 2018. When Corona hit, the patches were no longer being sold in this country. They could no longer receive them in this country. And I remember spending a good few weeks running around super farm to super farm, chasing these patches to no avail. And I ended up getting in touch with Panina, who then was able to change my prescription from this patch form to a pill form, which personally was much better. It just meant really the pills going into my bloodstream immediately. So it was like this for about a year or so. I was on 1 milligram of estrogen, and then I ended up spotting, so I had to up my dosage to 2 milligrams. So to say that things weren't necessarily so smooth, they were as smooth as they could be smooth, but it really meant me taking kind of the bull by the horns and leading my own medical journey, and taking care of my health the way that I knew that I could do best. And so I am still on these pills. I am, thank God, alive and well, and I am here to help in any way I can. If anybody has any questions, I'm more than happy to answer, but this is definitely a lifelong journey. It is not something that just, you have your ovaries removed and that's the end of it. You still have a significant amount of life left and a significant amount of health to take care of, and people who are relying on you and counting on you. And here I am, alive and well to tell the tale. But it is definitely something that that you need to be responsible for, and not to be afraid of, and to really just go ahead and do it, because no one else is going to take care of your health but you. So thank you. Anybody else?
Okay. Shira, I want to thank you very much.
Yes.
I just want to make something clear. I didn't give you the prescription. I arranged for you to get a
correct. But you were very instrumental. It was a rather trying time.
Okay. And really, thank you very much, because hearing your own personal story, it gives us an insight to what actually happens and how you faced it and where you are today. So thank you very, very much.
Absolutely.
Okay.
Pleasure.
All right, we are going to continue. We are honored to be joined this evening by Dr. Naama Srebnik-Moshe, who is Director of the Reproductive Endocrinology Services at the Sharsheret Medical Center. Dr. Srebnik is a specialist in obstetrics, gynecology, and fertility. She's a senior physician at Sharsheret Medical Center and the Department of Obstetrics and Gynecology and the IVF in vitro fertilization unit. But She not only works full-time in the hospital, but she's involved with other organizations like Sharsheret, where she is the member of the Medical Advisory Board, one of the members, as well as other organizations and societies. Just to give you an idea, and these are only some of them, the Israeli Society of Pediatric and Adolescent Gynecology, the Israel Menopause Society, where she's actually responsible for their website, the journal website. As I said before, the Israel Association of Obstetrics and Gynecology, and the Israeli Fertility Association, and ESHRA, which is the European Society of Human Reproduction and Embryology. With all that, she is also a senior lecturer at the Faculty of Medicine at the Hebrew University, and she's a coordinator of the BRCA medicine course at the Tel Aviv University. She is recipient of numerous awards as a result of her research in the field of fertility and topics related to the BRCA mutation carrier status. From a personal friendship, I can tell you that Dr. Srebnik puts her whole being into delivering treatment and care for that whole long list of her medical professionalism. She is something special. So go ahead.
Oh my God, I'm excited. Okay, so hi everyone. After this amazing introduction, I would like to dive into our issue. So let's start talking. I will share my screen. We will start talking, and at the end, we will even have some time for questions. So, life after surgical menopause. You just heard Shira, and I think that what she was very shortly briefing, the very short story that she tried to put into a few minutes is a life story, because it is challenging. It's not something simple. Sometimes we know that mastectomy is a large operation, very complicated, and you have to really think about it. And that the surgical menopause, the BSO, is very simple. You just go in, you go out, and in an instant, your ovaries are out, and oh my God, what did just happen to my body? And women are not prepared. So we need to prepare. And a part of it is what we're going to do today. Okay, so we all know, I'm not telling you anything new, that the chances of cancer diagnosis with BRCA1 and 2 mutation carriers are very high. I'm going to focus on the ovarian cancer risk. That we know that for BRCA1 carriers, we're talking about a cancer risk that starts increasing around the age of 35 to 40. And for BRCA2 carriers, it's a little bit later. So this is why we recommend the risk-reducing bilateral salpingo oophorectomy in order to decrease this ovarian cancer risk. And it's something that is well known, and it's kind of obvious that everyone needs to go this operation, really, to save lives. But what is the impact of removing functional ovaries? Now, we know that functional ovaries at the age of 40, they're very functional, because we have our periods, we ovulate, everything is very, very hormonal. But even if you were diagnosed at the age of 50, and if you still have estrogen in your system, even when you're postmenopausal, but very young postmenopausal, that means you're a year or two after your periods stopped, you still have estrogen in your system. So this operation might not go without implications. So why is it so important? Because we know that there are many tissues in our body that have estrogen receptors. It's the cardiovascular system. Of course, it's the breast, it's the liver, pancreas, adipose tissue. We all are familiar with the fact that people in menopause, the fat distribution changes from thighs to abdomen. Okay, like we know that things are changing. Bone marrow, musculoskeletal system, kidneys, our lungs, everything has something to do with estrogen. And we now took this estrogen from our body. So that might cause a lot of complications in the next years. But the main long-term consequences of early menopause that are documented in studies are the following. We're talking about vasomotor symptoms. We're talking about sexual dysfunction, vaginal atrophy, and all around the urinary system, more signs of atrophy and more relatively more events of infection in the bladder. Overactive bladder is more common after menopause. And we also talk about cognitive decline and Parkinson. We talk about cardiovascular risk. We're talking about death, increased death. And of course, the bones are affected by the loss of estrogen. So this is not something like a naive event. We need to address this major event of salpingectomy, of early menopause that we go into. Now, the symptoms, as Shira pointed, and also Penina, are very wide, but the most common ones are the hot flashes and chills, sleep disturbances, mood swings, thinning of the hair, dry skin. But I don't want to focus on the symptoms. The symptoms are something that we need to treat. Okay, there's no question about it. It might be hard. We might need to adjust the dosage. We need to start from 1 milligram, then add to 2. Some of my patients even get 3 milligrams of estrogen in order to fix this symptom issue. But that's not the only thing. Okay, and the reason I want to focus on the risks of early menopause is because I see many women that choose not to take hormones, and I do want to prevent that. So let's start with the cardiovascular risk. So this is a large study that was published in 2020 about type of menopause, age of menopause, and the risk of cardiovascular disease. It's a large study of 200,000 women. They're not BRCA carriers, okay? There were women from 10 different studies that all the data was collected, and they were trying to see why, what age, or what is the impact of the age that the woman undergoes menopause to the cardiovascular risk. So I just want to show you that there is a difference between natural menopause and surgical menopause. If you go to the right, the risk is higher. So you can see that after surgical menopause, the risk is higher significantly than natural menopause. And that's because women that go into natural menopause, even if in the same age, they might all be under 40, okay? They still have some estrogen in their system. Their ovaries are not dead. They're still a little bit active. But if the surgeries are in the pathology, then you have no estrogen. So the risk of cardiovascular disease and the risk of stroke is significantly higher. Okay, and as you can see here, we're talking about twice as much risk if you're under 40 and you chose not to take hormonal therapy. But if you do take hormonal therapy, you manage to fix it, but not completely. That means that even when we do give the treatment, then we need to make sure we give enough treatment and for enough time, and not to take hormones for 1 or 2 years and then say, oh, that's enough for me. We have to take the hormones at least until the age of natural menopause, which is 51. And I personally think that we need to even increase the time that we give the medication, because as I showed you, women in natural menopause still have estrogen in their systems. So I really believe that we need to give hormonal therapy for a longer time for an older age. And also we have to make sure we give enough estrogen, and it cannot just end with a medication. It has to also affect our lives. We have to make sure that we are physically active and that we keep our weight. And we will talk about this in a minute. Okay, so let's talk a little bit about mortality. This is another large study, 26 studies piled into like a collection of all the data of women undergoing surgical menopause. And you can see that all-cause mortality was higher in women that underwent the surgery under the age of 45, which is basically everyone with BRCA mutation, because we do recommend the operation to be done until the age of 40 or 45, depends on your mutation. Usually, mainly it's because of cardiovascular death, okay? almost twice as much as we said before. And we're talking about dementia risk and Parkinson's disease, and these are not things that you can just dismiss. The bone health, of course, is also something we have to address because it's measurable. We can do bone density tests and we can see where are the bones, and we can see that women that don't take hormonal therapy after their menopause, then there is a decline in bone health. And this can cause fracture, and we know that a hip fracture is also a cause for death. 33% of people undergoing hip fracture at the older age will die at the same year that the fracture happened. So if what we want to do is we want to prevent. Okay, the main thing in medicine is to prevent disease and not to fix it and treat it. So as you can see, if women were taking hormonal therapy, then the rate of women suffering from osteopenia, from decreased bone health, was much smaller than if you didn't take any medication. Okay, 16% compared to almost 50%. So we do have something in our hands that can alleviate the risks of surgical menopause and also treat the symptoms. And it's highly important to make sure that you get the medication. We have other health issues, as I said before, and this is a large study done in the Mayo Clinic in the States of women undergoing surgery under the age of 50. They were followed up for 14 years, which is quite a long time, and they checked 18 different health situations. What you can see is that depression was higher, depression rate. Of course, yeah, you're menopause at an early age, so you have depression. No, I'm just kidding. Hyperlipidemia, cardiovascular disease, as we said before, but also, which is kind of interesting, also risk for asthma, risk of lung disease, osteoporosis, of course, as we talked before. So we need to address these issues, and this is why the treatment is so important. And all the guidelines talk about the need for hormonal therapy in women in early menopause. Okay, so we're talking about, this is the North American Menopause Society. They changed their name, but I never remember the new name, so I still call them the same. This is from 2022, but they didn't change their recommendation until today, that we're talking about hormonal therapy, and this can help menopausal symptoms, bone loss, heart disease, and cognitive decline, and dementia. Okay, and younger women may require higher doses. Okay, and this is the main issue that we need to remember, that all the medications that you can buy, they're all trying to be very low dose. We're all kind of a post-traumatic from the time that the medical society was very afraid from hormones. They were very afraid because everyone thought that hormones cause cancer, breast cancer specifically. We're going to talk about it in a minute. And this is why people stopped prescribing hormones to women. And women were suffering. And it's not that they didn't care. They thought that the risk is so high, they don't want to give medication. Now we know that they were wrong. But from those days, the pharmacies and the companies lowered the doses of the hormones. So now if you want to have a higher dose of treatment, you need to combine your own medication. Take this from here and this from that, or take 2 pills a day. So it's more complicated and it's hard to adjust the dose for the specific patient, but it's worth it. So how do we know that it also helps women with BRCA? So we have several studies. This one is the one that only talks about symptoms, that you can see that women that did get HRT, hormonal therapy, it significantly improved their symptoms compared to what they had before, okay? We're talking about sexual function, we're talking about other symptoms, endocrine symptoms, hot flashes, and everything else. But we are still in this era that people are afraid, oh, hormones equals breast cancer, and we have a high breast cancer risk, so why should I take hormones? Okay, so let's address this issue. breast cancer risk with HRT for carriers. So we have several studies, okay? These are only some of them. We have several studies that examine this specific question, okay? Because you are a special population of patients. As you can see, most of the studies show that there is no increased risk, okay, of breast cancer in women undergoing surgical menopause and receiving hormonal therapy. Some of the studies even showed a decrease in the breast cancer risk, maybe because the women are more aware of their health, they're more into clinics, following them up, follow up and testing. We don't really know, but we do know that medication, hormonal therapy for carriers at the age of 40 to 45, even until 50, for several years, do not increase the risk of breast cancer. And there is even one study, amazing, that talked about a decreased risk of almost 20% of breast cancer risk for every year the woman was taking estrogen only replacement therapy. Okay, so this is really strong evidence. So when we look about risk factors for breast cancer, this is not related to BRCA carriers. This is the general population at the ages of 50 to 59. You can see that if there are 23 cases of breast cancer for every 1,000 women at these ages, if you take hormonal therapy, the increased risk is maximum 4 more patients. But if you take estrogen only treatment, then it decreases your risks in 4 less patients. If you're overweight, your BMI is over 30, look at the impact on your breast cancer risk. Okay, this is so much more important than taking hormones or not taking hormones. And we do know that menopause causes weight gain because our metabolic rate decreases. So we eat the same, but we increase our weight. So if I manage to give you a treatment that will keep your weight and you won't gain it and you won't become overweight or obese, I will decrease your breast cancer risk. Drinking alcohol also increases the risk of breast cancer, and smoking and many other issues. So we have control of our breast cancer risk, not completely, because BRCA is a much more significant issue than these small numbers. But if we manage to keep our weight, we do physical activity, we can affect our cancer risk.
Naama,
So-
excuse me, one second. That last table that you just showed, if you could go back to it, is that applicable to anyone or just BRCA carriers? Because there are people
This is
also
not
in
for
the
BRCA carriers. This is for general population at the ages of 50 to 59. This is not, there is no data here of who is a carrier and who is not. Okay, it's information from the UK, a national collection of their data on breast cancer risk. Okay?
Thank you.
This is not specifically for carriers. So what are the other strategies that we can do to decrease our breast cancer risk? First of all, there is no other answer than mastectomy, okay? Because if we really want to decrease the risk, we just need these amazing body parts out. But it's a complex decision. It's very hard to make this decision, and we do understand that. So we have some other strategies that we can do in order to decrease the risk of breast cancer when you are taking hormonal therapy. One of the issues that need to be addressed is, do we want to offer hysterectomy? Why should we consider hysterectomy? I will show you in the next slides that if you don't have a uterus, you don't need progesterone. And the progesterone is probably the thing that increases the risk of breast cancer among all the HRT treatment. So if there is a reason to do hysterectomy, for example, if you're very young and you have many years needing to take hormonal therapy, you should consider having a hysterectomy when you're taking out your ovaries. Or if you have uterine prolapse, if there are other reasons, if you have myomas or other reasons you should consider hysterectomy, this is the time to discuss it, okay? Because if we don't have a uterus, we don't need to give progesterone. Other options is give you natural progesterone. We have many studies showing the natural progesterone does not increase the risk of breast cancer because it's very similar to what our body was producing. Or there is also the option of no progesterone at all. I think that what Sheila was getting is kind of a treatment plan that she was receiving progesterone every 3 months, and this is like what she was talking about, producing her menses or bleeding. But there are also medications that don't have progesterone at all, and this is also an option specifically to women with high risk or to women that don't get along with progesterone because of side effects. Then there are HRT treatments without progesterone that still keep our uterus safe. So why is the progesterone such a bad guy? So this is that study 2002 that made women stop getting hormones for 20 years. In this study, there were two main groups. One group had a uterus and they were receiving a specific estrogen with a specific progesterone. And they showed that the combined therapy increased their risk of breast cancer compared to the women that got placebo. But if you were hysterectomized, you did not have a uterus, you were getting only estrogen, then your breast cancer risk was lower than the placebo group. Meaning, what they thought is that the progesterone is the problem. But progesterone is a name. We have almost 35 types of different progesterones, progestins specifically, okay? We have the natural, we have dihydrogesterone, we have noreltestosterone acetate, we have many, many types. We cannot compare this progestin to the other. And as you can see here, the women that received estrogen only in this specific study, the treatment did only good. Decreased the risk of coronary heart disease, decreased the risk of breast cancer, decreased all cancers, decreased fracture risk, and diabetes and many other things. So this is what we aimed. This is a treatment that I want to give you. Okay, so if you don't have a uterus, then it's very simple. But even if you do have a uterus, I need to find a medication that will be as similar to this. So even if I give you treatment, hormonal treatment, I don't increase your risk of breast cancer. Okay, so as I said, the strategies are either giving natural progesterone or lowering the amount of progesterone, okay, and trying to tailor the treatment to the specific patient. Until when are we going to treat? So that depends. All the guidelines say you need treatment until the age of menopause, which is around 51. But at the age of 51, you might have still risk, still symptoms. If you try to stop, you might have hot flashes because 80% of women, when they are menopausal at the age of 51 or 52, have symptoms. So why are you, the BRCA carrier, need to be punished because you have a BRCA carrier mutation? Okay, so we can also decide that we want to continue the treatment specifically to women that have symptoms. But as I told you at the beginning, I specifically believe I don't have any data to support this belief that I have, is that women that undergo surgery are not like other women that have early menopause because there is no estrogen whatsoever. And I really think that giving treatment for longer time, for the age of 55, is even better. But this can be discussed with your gynecologist or menopause specialist. And the reason I don't fear hormones so much, also because what we talked before, and also because you have a very large cup full of risk of breast cancer. And the hormone therapy is just a drop in that cup. So even if there is an increased risk, it's probably not significant. So we can feel very confident in getting treatment and making sure that we don't suffer from other issues. Tailoring the treatment is might be complex. Usually a woman, as you can see here, there are many types of women, many types of bodies. As we look different, our body inside is different. So one woman will be fine with one medication, and the other one will need a different medication, and a third will need a higher dose with a third medication. So it might need tailoring, and you need to be very, very patient. Usually what I do with my patients is they get a prescription to start the day after the surgery, and they start the medication, and we meet after a month because I need to know if they're fine or not. They're supposed to be the same as they were before. And if they're not the same, I will increase the dose. I will change the medication until I find the right one for that patient. So it takes time, and you need patience. And you need to be able to suffer a bit, because we might not be able to find the right specific amazing treatment for you on the spot. But it will work, and it's a long distance run, because now you're 40 and you need to take this treatment until the age of 51 at least. So it's worth this effort, even though it's quite complicated. I want to talk a little bit about the non-hormonal options, because some of some of the women already had a breast cancer diagnosis, and this is how they found out that they are BRCA carriers, and not all of them are eligible to get hormonal therapy. So we know that if you can't take hormones, then it's quite complicated. All the medications that I can give don't affect this risk of dementia, of coronary heart disease. We will have to work much harder to decrease that risk. But at least for the symptoms, we have some options. So what are the options? We have options of herbal medicine. Most specifically in Israel, we talk usually about black cohosh, but also on a complex of many herbal medications together. We can talk about acupuncture, about CBT, psychological treatment, and we also have very new drugs that are coming now. One of them is already in Israel. The other one is coming to Israel, and I know that both of them are in the States, that are specifically working on the hypothalamus, where our body controls our temperature. Okay, and it's a medication that counteracts the effect of not having estrogen, and it works very, very nice on hot flashes. The new medication also can affect sleep deprivation, but we know that we have more options, although they're not perfect and they're not hormones. Okay, so but we do have something in our arsenal. One more thing that we need to discuss before I will open this meeting for questions is androgen treatment. Androgen treatment is a big black hole, and that is because there are no studies on women and androgen treatment, and almost nowhere in the world the androgen treatment is listed for women. So what we do is we give a medication that is meant for men, and we try to adjust it, the dose and the treatment protocol, to women. But we do know that the North American Menopause Society and other societies related to menopause talk about the need of androgen treatment in women that suffer from hypoactive sexual desire disorders. Now, a regular woman has two places that the androgens are produced. One is the adrenal gland, and the second is the ovary. Even a menopausal woman will still have androgens from her ovary. Less, but she will have. So the chances of suffering from this disorder are quite low for women that go into natural menopause. But if we took out your ovaries, okay, then the chances of you suffering from hypoactive sexual desire disorder are much higher, although the adrenal gland is still working. So it's not automatic that you need testosterone treatment, but there is quite a chance that you will need it. So we're talking about 5 to 10% of women undergoing surgery that will need testosterone treatment. We don't have enough safety data regarding BRCA carriers and testosterone treatment, but we do know that breast cancers usually don't have receptors for androgens, so it's probably safe, although we can't say that for sure. The treatment protocol is quite complicated, as I said, but there are many ways to overcome this issue. And it's quite common that a woman that underwent BSO, bilateral salpingo oophorectomy, will need testosterone treatment as an add-on to the estrogen treatment that she is receiving. Other health recommendations is just make sure that you're taking vitamin D and calcium and do physical activity, because this can decrease your cancer risk, and it will keep your weight, and it will make you healthy, and it will decrease your risk for cardiovascular disease and probably many other things. We recommend usually doing a bone density scan when you go into menopause, so we can follow up and see that you're receiving enough hormones. It's quite a kind of a way to make sure that the treatment is enough, and try to make sure that your weight is stable and inside the limits of normal BMI, and overweight is also okay, but don't go into the obese part. So this is what I wanted to say, like on a, very short. I'm open to discussion and questions because there are a lot of things that we can talk. And I thought it would be easier to just do it while questioning. Okay?
All right. So first of all, thank you very much. It's a great opportunity to get this information. There are some questions. I know they came before the webinar. It came online, but there are some that came out now, and I think I'm going to present some of them. Is there a risk with hysterectomy beyond the typical surgical risk? For example, when it comes to hormones or use for a uterus, are there extra risks?
It was thought that it might affect sexual function, but now we know that it doesn't affect sexual function. So the only risk is the increased risk of the surgery itself. And this is why if there is any other reason you need to do the hysterectomy, then just jump on the option. And also it needs to be discussed. So I usually recommend hysterectomy for women that are very young and that need to get hormones for a longer time. It can also easier to control all the side effects, because most of the side effects of hormonal treatment are progesterone. And if you don't have a uterus, you don't have to take progesterone. So you won't have side effects, and you'll be happy, and your doctor will be happy, and everyone will be happy. So no, the only risk is the operating risk.
Okay, so on that issue, somebody wanted to know if it's beneficial to have an IUD containing progesterone along with estrogen only HRT.
Okay,
if a woman keeps a uterus. What are your thoughts?
There are two issues about that. One is the cancer risk, and the second is the treatment. For the treatment, it's very simple. If you have a progesterone IUD, then we love keeping it because it can help us not give you progesterone systemically. And as I said, you will have less side effects probably, be easier to control the bleeding, the spotting. It's not bleeding. We don't want you to bleed. So if you have an IUD, keep it in. It's also an option. Usually we can offer putting in an IUD while we're doing the BSO in the same surgery. So it's a good option. Cancer risk related, we don't really know. There are some studies saying that the risk of cancer, breast cancer, is quite similar to taking contraceptive pills. So we don't really know if it's safer than taking natural progesterone or other HRTs. But my belief is that, again, this should not be the issue. The chances, the risk of cancer because of the mutation is so much higher than any medication that you will choose to take. So this, according to my medical, I don't know how to say the advice, should not be a reason to choose or not to choose the IUD. It's much easier if you have an IUD to control the bleeding. That's for sure.
Okay. Could you address the difference between synthetic and bioidentical hormones? Are all lab HRT synthetic?
Okay, it's nice. It's a good question. Okay. Bioidentical hormones are a problem because they've not been studies and they're not authorized by any how not the FDA,
Official.
not the Israeli, not official. Yeah. So bioidentical are a problem, especially the ones that you buy on iHerb without a prescription. The estrogen that we have in the HRTs that we use, most of them are natural estrogen. They are synthesized in a laboratory, but they are equivalent to the natural estrogen. So, except two specific types that are not so common. If you want to have very natural hormones, you can have them inside the medical box. Regular estrogen, natural progesterone, and you don't need to go to the bioidentical that we don't have enough data on them.
Okay. I just want to remind people that the participants here that some questions we cannot address if it's a personal situation. So I may change them a bit. Like, for instance, what are the advantages and disadvantages of a transdermal HRD patches? And we cannot actually relate to specific names or
Brands.
manufacturer, what's it called? I can't say it in English either.
Yeah, nice. It's not only my problem. Okay, so that transdermal and oral are a bit different. First of all, if you have any risk factors, we would rather give you transdermal. For example, if you're smoking, we would rather give you transdermal. If you're obese and you have hypertension and prediabetes, we would prefer to give you transdermal treatment because it's kind of less risky. The other advantage of transdermal is that it does not affect libido. The oral can not, it doesn't decrease, nothing decreases libido, okay? Nothing. Everything is good for the libido, but the transdermal might be even a slightly better, okay? But the oral medication is sometimes easier to use and also decreases lipids. So it's better for someone that has mild hyperlipidemia. So basically, at the end, you can choose whatever is easier for you to take. If it's easier for you to take a patch, go for the patch. If it's easier to take a pill, take a pill. If it's easier for you to take a gel, go for the gel. Where the only important thing is that you will take the medication at least until the age of 51. So whatever is easier for you.
Okay, I just want to remind the participants we cannot open it for direct questions. Oh, if you have any questions, just put them in the chat. I'll try to get to as many as possible. Someone wrote about the problem of hypercoagulability. Can they take hormones? What's available?
Okay,
If
so
not.
that's a very good question, and that depends on the age and the type. Okay, so for example, some types of hypercoagulation mutations, if you'd never had a personal or family history, can get transdermal hormones. Others, we might decide with the hematologist that is treating this specific patient that we will give anticoagulation treatment with the hormones because we believe the hormones are so crucial. So we have several patients getting a type of anticoagulation with HRT. And it's specific for each patient according to the risk, to the age, and all those issues that we need to take under consideration.
So in continuation to that question, somebody asked if blood thinners are necessary with transdermal. That's what you said, that would speak to the hematologist?
Yes, it depends on the type, because there are several types that you don't need blood thinners with, and others you do need. So it's specific according to the family history.
Okay. What would you recommend or suggest for someone who had hysterectomy due to uterine cancer? And they wrote here, and cannot take HRT?
Yeah, it depends. There's some types of uterine cancer, they can't have HRT, depends on the type and the spread and the grade and stage. So it's specific according to the age and the symptoms, and we need to find something that is non-hormonal. It's a discussion with the oncologist and we will try to find something. It's either this NK3 receptor antagonist or herbal medication or acupuncture. We try everything until we find something that helps.
Do you recommend doing a complete hysterectomy and ovary to BSO removal during a C-section delivery? Or would you
No.
advise against it
No.
postpartum?
No, it's complicated and everything can bleed. It's not a good time. No, separate operation.
Okay.
A
And
BSO
what
can be
about
done during during a cesarean, but not hysterectomy. It's not a good idea.
the risk of endometrial cancer with HRT?
Well, this is why we're giving a progesterone. So the risk of very, very, very low, and they're treatable. Usually, the main symptom of endometrial cancer, the type that is related to HRT, the symptoms are bleeding. So if you're bleeding, we will probably check your endometrium, and then we'll know, and then we'll treat. You won't even have to go hysterectomy. Usually, we just finalize the treatment with medication. So it's not so complicated, and the risks are not high. So this should not be an issue to think about. There is a slight increased risk of endometrial cancer for BRCA carriers, but it's a different type. It's not related to HRT, and it's not a reason to recommend hysterectomy.
Okay, and what do you think of the last research of removing tubes only, subinjectomy, as a preventive measure?
Okay.
That's a
So
whole topic on its own.
it's a whole topic. There's a lot to talk about. There hasn't been yet a study with cancer cancer prevalence, okay, for the women that delayed the timing of BSO, okay? So they don't have this data yet, so we can't say for sure if it's safe or not. Okay, what is optional is if you want to remove your tubes at the age of 30 and then delay the oophorectomy to the age of 40, that you can do. But having oophorectomy at the age of 50 because you took your tubes is not supported yet in the literature. It will be in a few
And
years, but not yet.
is estrogen and testosterone the preferred starting treatment for HSDD?
Okay, so usually only estrogen is needed or progesterone if you have a uterus. Testosterone is needed only if 5 to 10% of women. So I usually don't start with it. I give it a shot with estrogen in a full dose. And if still needed, then we add the testosterone. There's also testosterone ovules that you can insert vaginally that can also sometime do the trick. And if not, then you go for the full testosterone treatment.
One other question, should you take progesterone even if you had your uterus removed? I think you addressed that.
No, it's a debate. Like the medical community thinks not, but there is specific researchers that think that progesterone might be important for the brain. So, but if any progesterone, it needs to be the natural progesterone. Okay, so if you take anything, it should be the natural progesterone. But there is no reason today to recommend this treatment if you are after hysterectomy.
Okay, we only have a few more minutes, so this was one question that came in during the registration. Any advice on what you can do if your body stops absorbing estrogen? The levels will go up, like this person was describing, that levels may go up for a while, but then they drop again. What are your thoughts on that?
So we need to change the way of administration, because some women, when they take orally after a while, for several reasons, it doesn't work anymore. So we switch to transdermal, or the opposite. We can combine medications, for example, a gel and a patch or a gel and a pill. It happens, it's quite common. And I think this is the way to address, just give it from different ways. So it will be absorbed in different modalities. I saw a question about until what age. So I'm just going to say that there is no limit. Okay. If you need the medication, if you need HRT for symptoms, there is no limit. You can continue until the age of 120, Bezlat Hashem. Okay. So as long as you need it, you can get it. Okay.
Okay. Actually, I think we only have a minute left, and then I have to wrap this up. Let me see if I can find what it says in the chat. One more minute. Do the non-hormonal options that you suggested help when it comes to cardiovascular disease
We don't know yet because
or symptoms?
yeah, they help for symptoms. We don't know about the cardiovascular risk because there's not enough studies on that. Some of, like for example, the herbal medicine might be beneficial, but it's not the same as HRT, that's for sure.
And at what point should an endocrinologist manage HRT versus a gynecologist?
Yeah, if the endocrinologist feels safe, not safe, you know,
Sure of himself?
sure of himself, then he can do it. Great. It depends on the not every gynecologist understands in HRT, and not every endocrinologist understands in HRT. So you need to find the right doctor that understands and doesn't fear the medical treatment, and it doesn't matter which kind of doctor he is or she.
Okay, so I think our time is actually up. I want to thank you very much. And I do want to say that if someone has questions, you can send them to me, and I will, if Dr. Srebnik agrees, I will refer them to her, and I will send you the answers by email or by WhatsApp, and my information is in the chat. Okay, so I just want to wrap up and thank you again, and ask you all to please take a moment to fill out the survey. It's in the chat box. And I want you to remember that Sharsheret is here for you, and we are here for you and your family in the US and in Israel. We try to provide as best as we can emotional support, mental health counseling, and other programs to help you navigate you through whatever cancer experience you're having, or even if you're high risk and you're having a difficult time dealing with it, just turn to us. We're here for you. There is no cost. It's completely confidential. And again, our contact information is in the chat box. So thank you all for joining us. I hope you enjoyed it, and good night.